fluoroscopy we would use to, for instance, to place an NG tube. So I've gone down on multiple occasions. Patients were on mechanical ventilator, so I ended up bagging the patient with an ambu bag while they were getting this fluoroscopic exam to place a feeding tube. So I'd be breathing for them. I'd have lead on, but I'd be breathing for them as they place this tube. Fluoroscopic examination is real-time X-ray images. So you could see this tube going down into their stomach, into their large bowel, first of all, into their jejunum, to make sure that it was in the right spot. So that's the reason you take a patient down under fluoroscopy, is place an NG tube or a feeding tube. Angiography, we might want to get moving pictures of a radiographic dye that's going through the carotid artery or through the coronary arteries or through the veins in the arteries in the legs. So we might want to get specific images of particular parts in angiography to make sure that there are no clots or blockages. So specific examples of why you'd use one radiographic technique over another as an ancillary exam.
And in angiography, would that be like a good one for like a pulmonary embolism?
Yeah, absolutely, because you're looking at blood flow.
Those also in real time?
It's in real time. You actually look at blood flow, frame by frame, but it's an X-ray. It's a frame by frame X-ray looking at blood flow.
Okay, so it's like not on a monitor.
Well, it can be on a monitor. In most radiology departments now, every image is visualized or seen from a monitor. Back in the day, I used to have to go down to the basement and pull a patient's X-ray and actually physically look at an X-ray. Now you can get it at any computer terminal in the hospital. Within minutes of having taken that exam, usually within 4 or 5 minutes, you've got an image. So it's really improved what we can see and what we know about the human body by looking at these different images. Why would you use a PET scan as opposed to a CT and an MRI?
Are you asking?
Looking specifically at tissue densities, yeah.
And metabolic activity, right?
Yeah, exactly.
Are the PET scans the one that sees the metabolic?
Yeah, exactly. Yeah, that's what Hannah was saying.
That's not just
Exactly word for word. I know it takes a while to travel from
So I'm doing something.
You're doing good, no worries. So radiographic and ancillary radiographic techniques. Why you use them. Let's see, what kinds of other questions? I know on the final exam for patient assessment there are 4 essays.
Are we doing a review right now?
Not specifically, but I'll just let you know.
I have a question
Go ahead.
about all of the exams.
Yeah.
So this one for A&P opens when?
Through the 9th, and I can open it today through the 9th.
Okay, and then this
I
next.
don't want to hurry yet. And then the final will be next week through the 15th.
Next week through the 15th. Okay, and then this patient assessment one.
And then the patient assessment one will be through finals week as well, because it's a final for patient assessment.
We'll have reviews for both of them.
Yeah, we'll do reviews for both of them.
Okay,
So we'll have 5 tests this week.
Hi.
In the next couple weeks.
That's why they
That's why
call
I'm
it.
gonna take this one on
Actually,
Monday.
this next
Start.
week is called Dead Week
Yeah, I get it.
for a good reason. It's preparing for all the damn finals that are coming up.
Yeah.
But 20, look at what you've learned in 15 weeks for 20 credit hours, no less. Holy
Yeah.
cow!
Yeah.
20 credit hours and that's one of the reasons why we're going to be able to finish by next
December?
a year from now. Exactly a year from now.
Stop it. That gets me so
Oh,
excited to hear that.
It's not. It's really exciting for me because I know you're all capable and qualified. We've been really impressed with what you've learned and how you know it. So for specifically X-ray questions, I'll tell you which ones they are next week. I don't want to fluster you.
So wait, we are doing the review right now?
No,
Sorry.
next
Okay.
next week.
Okay.
I know, we're like,
I don't want to overdo you.
Okay, I understand that. I make clinical students as well.
Okay, what other kinds
Let's do it on the next.
information would you want to know about a chest x-ray? Some things I asked about how you might visualize or what you might see on a chest x-ray. And particularly how certain pathologies would look. So how would you describe to someone, if you had an x-ray in front of you, how would you describe, oh, that's a pleural effusion? You should be able to say that in 3 words. That's,
What do you say?
have Kyle help you and then move it down to this side of the table.
Do you say
Blunted
costophrenic?
costophrenic angles. So if you were to describe exactly what a pleural effusion looked like on an x-ray, I would just give the terms. Well, that looks like a blunted, I mean, can you see it in your mind too? What a blunted costophrenic angle looks like? So you just know that usually posteriorly, the angles go fairly far down posteriorly. When you've got an AP film, those angles are just blunted. They're rounded rather than sharp, well-defined angles down to a point on the posterior sides.
So you said EP and PA, so which one would you do for a pleural effusion? Both?
You could do it on both, but the thing is that if you had a right pleural effusion and you were turned this way and got a lateral film, you wouldn't be able to tell on the lateral if it was in front of or behind, because again, it's a 2-dimensional black and white picture that you're looking through the human body this way. So you wouldn't be able to tell if it was right or left. If you're this way, oh, that's definitely a right pleural effusion.
Wouldn't you do the decubitus? Whatever
You could do that one too, exactly right. So you could turn them on their side and do a decubitus lateral.
Okay. Well,
Yep. So that would allow fluid to drop to that side and you'd see an air fluid line, an interface that would be pretty sharp and well defined, and that would be diagnostic as well. So
and that's all over in the lung. It's not confined, right? Like it's.
it is. The pleural effusion is in the pleural space around the lung. It's not in the lung itself. It's around the outside. So I'm trying to create visual images so you can tell what these things look like and what you know as you're helping to assess. The X-ray is the assessment, right? The X-ray is what you're using as the assessment technique itself. How else would you be able to tell if there was a pleural effusion? What other assessment technique would you use aside from an X-ray to see that there was a pleural effusion?
To see, or like couldn't you do percussion?
Oh, that is great. Is that what you guys were saying?
A what?
So you could actually do percussion
Yeah.
on a patient's posterior rib cage to hear what kind of a note would you hear?
dull.
Yes, you sure would. You'd hear a dull note to percussion. So that's a very classic way to describe on the national board exam how you're identifying a pleural effusion on the right or on the left. Is you'll do percussion and it'll be dull to percussion. The sound doesn't travel as well, but then the X-ray confirms your suspicion. So we can usually find through assessments very easy, non-expensive ways to do it. The X-ray happens to be, a $100 picture that confirms exactly what we thought. Yep, there's a pleural effusion down there. So it's dull to percussion. It's interesting the amount of assessments that we do that you should be able to make a kind of an assumption about what's going on in there and how the lungs are influenced. So dullness to percussion would help to diagnose a pleural effusion.
So as far as like the radiology tech would go, you give them the information. Let's say you hear it on the right side.
Mm-hmm.
You'd give them that information, and they would do accordingly, or would they still just do all their angles?
They just do an AP film, and what's interesting is that the radiologist doesn't say that's a pleural effusion. They'll just say diffuse density in the right lower lobe. They won't say, and they rarely will diagnose a patient. They'll describe what they see in radiologic terms. For instance, when we see a patient with ARDS, how does a radiologist describe that?
Ground glass.
Ground glass appearance. They won't say patient has ARDS. They won't diagnose with a radiograph. They'll say in the description, left lung appears a reticulogranular pattern or ground glass appearance. And they're using code words to describe certain pathologies. They never come out and actually define or diagnose the pathology.
They're physicians, right? Can't they do
They are.
that?
They
I
are.
mean, they went to a lot of school.
Many of them are. One of them I became acquainted with. He said on his board exam, 9 of the 10 X-rays, they were looking for pathologies. 9 of the 10 were normal. So that was a hell of a simulation, right? If on your board exam 9 of the 10 were absolute, so you'd go through a systematic approach and you'd try to make a diagnosis when most of them were normal.
Oh, man.
That's a hell of a joke to have to go through. So pleural effusions can be described in a particular way, and we want you to be able to understand and be able to write out in words how you'll understand those appearances. How would you see, or how would you know that there was a pneumothorax? What kinds of assessments could you do for a pneumothorax?
Percussion again.
You do percussion again, what kind of note would you hear?
Hyperresonance.
Hyperresonance. They use those particular terms, hyperresonance to percussion. So dullness with fluid, hyperresonance for air. So if you hear air that's hyperresonant, what about breath sounds? What would you hear if it was a pneumothorax on the right again? You'd hear hyperresonance to percussion. What about breath sounds? Would you hear air going in and out of a collapsed lung? Probably not. So diminished breath sounds. And then you get a chest x-ray, sure enough, you can see a clear, I mean, how would you distinguish the lung from the pleural space in a pneumothorax? What would it look like on an x-ray?
Translucent, black.
Yeah, with no vascular markings at all. So I think in the assessment book there's some pretty good X-rays of pneumothorax. Let me see if I can find them real fast.
Yeah, there's a chapter.
There he is.
327.
Thank you.
Chapter.
So on, yeah.
332. Picture of an X-ray.
So hyperresonance to percussion. Look at that on page 332 on the right-hand photograph in the right lower lobe of that X-ray. Right lower lobe of that X-ray. No vascular markings in there. It's just hyperlucent. So it's really, really black. If lung tissue was encapsulating all that area, you would expect that there would be, at least vascular markings, but you can see where the lung stops and the air starts, can't you? Even all the way up the side. You see where that happens. So on that photo.
Right there.
Here's a question.
Yeah, this one's
Maybe I'll-
Exactly.
but-
Well, you can see even right there. So this is air outside of there and down here. The trachea is deviated, so what does that tell you? Yes, so what's that called? Yeah, the trachea is deviated. What's it called when the lung is moved out of the way? Yeah? What's it called when there's pressure that's pushing the lung away?
shifting away.
Or is it that?
What's that called? How about tension?
Oh.
Tension pneumothorax. So how would you tell? So you'd be hyperlucent to percussion. How else would you be able to assess that there's tension pneumothorax? Palpation, absolutely, Alicia. Specifically that the trachea is deviated from midline, right? So it's deviated away from the affected side. So it's being pushed away from the affected side. So again, you wouldn't need a chest x-ray to confirm a tension pneumothorax. Patient would be short of breath. They'd be tachypnic, tachycardic. You could do percussion and hear hyperlucence to percussion.
Really sound.
tympanic really, because it's full of air. And with palpation, you'd feel the trachea shifted away from the affected side. Then you get a chest x-ray, sure enough your suspicions are confirmed. It's a tension pneumothorax on the right, shifting it away to the left. So a tension pneumothorax. Let's see. I'm not sure if there's a photo of this one in the patient assessment book, but I'll check. So if a collapsed lung or a pneumothorax of the chest shows hyperlucence or deep dark black airspace, what would pulmonary gas, okay. What can you surmise that a pneumopericardium would look like? What would a pneumopericardium look like?
Enlarged. Look like the heart's.
Black.
So it may shift the heart. You couldn't do palpation to find out. So you'd need an X-ray to find out. But what would you see around the heart?
Black.
Black, exactly. If it's a pneumopericardium, that means you've got air in the pericardial sac. So you'll see a sliver of air around the heart, and it'll show up black. So an X-ray would really, what kinds of signs or symptoms in your assessment could you assume that maybe there was a pneumopericardium? What do you think would happen as the heart, especially if there was tension in there?
It wouldn't,
Cardiac
you wouldn't
tamponade.
be able to hear the heartbeat very well either.
Heartbeat would be diminished. And what about blood pressure?
It'd go up.
Blood pressure would start to go down, especially if it was under tension. Okay, so there are clues, there are subtle clues in assessment that we can understand that something's happening. You know, patients are tachypnic, tachycardic, their blood pressures are going down. You know, there are subtle signs, if we can connect them through assessment, to determine that patients are suffering from particular pathologies. In a pneumopericardium, what kinds of situations would result in a tension of air around the heart?
Sorry, will you say that again?
What kinds of pathologies, what kinds of circumstances would you think to assess for a pneumopericardium? Would this be just any patient on the floor?
No.
Where would you see him?
Trauma.
Yes, exactly. You'd see him in a traumatic injury, car accident.
Can we call from an MI at all? No, right?
Probably not air in the pericardium, but from trauma, definitely. If they're involved in an auto accident, then you start thinking of things that could shift and tear inside of there. And you know, one of the worst ones I remember specifically was a transected aortic aneurysm. 18-year-old, alert, aware, was involved in an accident. The physician heard diminished breath sounds over the left side of the chest, decided, thought that it was a pneumothorax on the left, put in a chest tube. The pressure inside of there was keeping the aorta closed, and she drained out all of her blood inside 2 minutes and was dead.
Should she have done a chest x-ray first?
Yep, we should have had a chest x-ray first before we put a chest tube in. So those things happen. Unfortunately, they do. And so simple assessments can help you to understand what's going on, and a chest x-ray in this case would have probably saved her life. But we didn't know at the bedside at the time. Now, she was alert and responsive and oriented, and she, you know, an 18-year-old, but the traumatic accident shifted her aorta, it caused it to tear, and the pressure inside of there was keeping the tear closed, so to speak. When the pressure was released, she was allowed to bleed all back into a chest tube, and she exsanguinated basically and died. So we've got to be better assessors at the bedside.
Is that considered like the body's, defense, like a defense?
No,
Or did it just coincidentally happen?
that was a coincidence, but under the circumstances, we didn't do a chest x-ray first to make sure, the physician thought that it was a pneumothorax. And so they were gonna just drain the air out. She was complaining of shortness of breath. She was diminished breath sounds. She was, I don't know, I don't remember if she was percussion, if she had a hyperlucent sound to percussion. What were you gonna say, Hannah?
Oh, is it protocol in situations like that to get an x-ray before?
Not always. Not always. The situation sometimes demands detracting from protocols, although we're relying on protocols more frequently than ever before based on outcomes. So usually you get a chest x-ray.
Probably depends on where you are too. Is
It-
it like
it-
IMC? They would always bring a chest X-ray. 'Cause
Absolutely,
they
it
have
depends
a
where
ton
you.
of techs and a ton of.
And there's the difference between large hospitals and small hospitals. You know, at a large trauma center, they'd have an x-ray before they did anything. In some places, traumas come in, they put them through the CT scan before they do anything.
Yep.
They don't even touch them, they're going through the CT scanner. Oh yeah, I can see a transected aortic aneurysm. Well, let's go to surgery and do this under controlled circumstances. It would have saved your life. But you'll see things that just make you shake your head sometimes. And it's circumstance and it's emergency, and what happens in trauma situations sometimes can't be quickly controlled. And it'll really open your eyes, that's for sure.
So did that one happen at a trauma center, or was
That
it?
was, and it was, if I can remember, it's probably been more than 20 years ago, but
Okay.
it stands out in my mind
I
as
bet.
a classic example. You know, that and, you know, those kinds of traumatic things that just, I remember that as an experience that I now hopefully you can learn from. So pneumopericardium, you'll see a sliver of black, a translucent black sliver around the heart that's usually under pressure. Pleural effusion, pneumothorax. How would you, we've already talked about ARDS. You see ground glass or reticulogranular pattern. There's probably, is there an x-ray in the assessment book?
Yeah.
We just did that on Tuesday, so.
Oh, did you?
Yeah.
Okay, so ground glass appearance, those are really, really common. The interesting thing about ARDS is that we're often left with hypoxemic respiratory failure. So PO2s are low, CO2s are high. We're often left with a disease pathology that is refractory to oxygen therapy, if you're familiar with that term. So the more oxygen you give, the PO2 doesn't increase appreciably. So you might have a PO2 of 40 or 50, you give them 100% and their PO2 goes up to 52. That means that they're refractory to oxygen. But in ARDS, we often give pressure to help to ventilate and oxygenate, but it has a simultaneous effect on hemodynamics. So on the one hand, you're raising pressure to improve oxygenation and ventilation. On the other, your blood pressure is going down. So at what point do you accept minimal oxygenation and ventilation with the least effect on hemodynamics? And we're often faced with that decision. There are no parameters that are tried and true that you can always rely on. Some patients it's pressure, some it's volume, some it's APRV, some it's inverse IE ratios. So you have to have strategies that we'll go over in a lab next semester, mechanical ventilation strategies that you can rely on. If one tool doesn't work, you use another tool to achieve the same ends. We might use low tidal volumes with fast respiratory rates, or low stretch protocols, or permissive hypercapnia. We'll allow CO2s to go up, even though we know they're going up 50, 60, 70 millimeters of mercury, at the expense of too big of an influence on hemodynamics. So you'll have to learn to balance the positive pressure effects or the I think you've probably heard this in terms of barotrauma. Barotrauma in terms of hemodynamic influence. And we're often left in ARDS with circumstances that you have to mitigate the two. And there's no right answer for any one patient. One will be treated one way, another will be helped or influenced in another way. So that's the paradox you'll be left with in adult critical care when you're in those units, is that you'll be making the decisions. Physicians will ask you, well, what do you think? Do I go up on rate and volume, or do I minimize blood pressure? And I can't tell you there's a right answer for that.
So do a lot of times we just don't even have time to figure out the best way, and they pass away before we.
You usually start somewhere, and then it's not like it's a now or nothing. Usually they'll deteriorate, and then we'll make other adjustments, and we'll try to do. But there are often paradoxes that neither one will work. It's not all this way or all that way. We're often balancing somewhere in the middle.
Mm-hmm.
And I've seen patients go on like that for weeks. So ARDS, pleural effusions, pneumopericardium, pneumothorax. How about subcutaneous emphysema? What would that look like on an x-ray? How would you be able to tell through simple assessments?
Bubbles. Crackles.
Crackles, yes indeed. How would you feel crackles that you would discover as subcutaneous emphysema?
Can't you like push on them?
You do, you absolutely do. And it usually occurs in their upper chest to begin with, in the neck
In the
and
eye.
upper chest, and then that transmits up into their eye sockets.
Yeah, I've seen it.
Have you?
No, well, not live, like I saw a
Not
picture.
live.
Oh, you did?
No, not live, not live. I just saw it.
Probably the worst subcutaneous
Aw.
emphysema ever.
Yeah.
This 9-year-old lady,
That's horrible.
her entire family kept trying to keep her alive to sign a will.
Oh,
So in order to keep her breaths normal, we had to put her on BiPAP, which was only making it worse. We decided to take her off of it without the family's permission though, with doctor consent obviously,
yeah.
because it was literally like, she was tiny little thing and then the skin was inflamed.
Oh my goodness.
Probably 3 or 4 inches out.
Wow.
And they kept trying to not give her morphine and stuff. It was pretty bad, but it was probably the worst case I've
Yeah.
ever seen. Her
So-
entire arm was swollen, probably to her elbow, just all of it, all the way.
Oh man.
Wow. The worst case I've seen is sub-Q in their shins.
Ooh.
So it had gone, they were on positive pressure ventilation, but it had gone through the mediastinum into the gut and down into the limbs, into her legs.
I just like imagine their skin popping. Does
Yeah.
Yeah, it's like some
You
of
would
them
think,
bad.
but
Oh.
if it,
Oh man.
and we usually see it in trauma, but positive pressure we'll see it, and it usually absorbs over time. It'll reabsorb into the tissue, so it doesn't require treatment. It's just a condition of barotrauma that gets worse, and we're sometimes left with the marks. But it can be easily assessed with just palpation. You just push and you'll feel Rice Krispies crackling beneath your skin.
Oxygen after like
So it
3
does the
hours,
skin
it
ever
was
pop?
just like so much better.
So there are simple assessments that we can do. The chest x-rays, the radiographic techniques that's icing on the cake. We can usually see and distinguish these kinds of conditions. But I'm going to ask you simple assessment techniques and then what you'd see on an x-ray. How would you describe seeing these pathologies on an x-ray?
This is gonna be a rough test.
I think it's going to be easy. That's for Caitlin, it would be way easy. I think the test is only 30 questions, and believe it or not, Jimmy, there's a bonus.
Oh.
Why is it me?
30 questions is a bonus. Something we have to calculate, but we'll talk about it next week.
Sounds good.
All righty, well, stay warm and dry out there, stay out of the snow. And have a very good